Boa noite a todos. Meu nome é Giuliano Bedoschi. Eu sou o diretor científico da Sociedade Brasileira de Reprodução Humana e sou o coordenador do Comitê de Oncofertilidade da SBRH. E eu estou vindo aqui, é uma satisfação, apresentar o nosso webinar Avanços em Oncofertilidade e Preservação da Fertilidade em Situações Especiais. E para esse webinar, eu tenho a honra de apresentar as nossas duas palestrantes. Primeiro, a doutora Terri Woodard. Ela é professora associada do Departamento de Ginecologia Oncológica e Medicina Reprodutiva no Hospital MD Anderson, e ela vai estar compartilhando para a gente a experiência em preservação de fertilidade em pacientes oncológicos e também dividindo um pouco da experiência do serviço. E a doutora Jacqueline, que ela é diretora do Programa de Preservação de Fertilidade Feminina no Children's National Hospital, do NIH, e também ela é co-chair do Oncofertility Consortium, o subcomitê de casos não oncológicos. Eu gostaria também, antes de começar as apresentações, avisar que no final da apresentação a gente vai estar distribuindo o link para solicitar o certificado, tá? Então, até o final das aulas, a gente vai estar disponibilizando o link no chat, tá? Então, para quem está querendo o certificado, é só clicar e acompanhar a gente que a gente vai estar liberando. Eu espero que vocês tenham um ótimo webinar. E agora a gente vai começar, então, com a apresentação da doutora Terri. Terri, please, the stage is yours.
Awesome, thank you. So thank you all for inviting me to speak this evening about something that I feel incredibly passionate about. I was tasked to give you some background as to how to build an oncofertility program. I arrived at MD Anderson about 12 years ago, and at that time, nothing was in place. So just wanted to share with you today some of the things that we did to strategize and make this program a success. I do not have any disclosures to report. And my objectives today are several. One is to provide a very, very high-level overview on building a successful oncofertility program at a national comprehensive cancer center. And then I will outline some of the developmental pillars that define the program, and finally demonstrate how they all converge to improve patient access to high-quality oncofertility care. So first, I'd like to talk a little bit about cancer and children and people of reproductive age. And this is US data, of course, but approximately 9% of the US population is diagnosed with cancer under the age of 45. And this estimates to be about over 10,000 children between the ages of 0 and 14, and about 88,000 adolescents and young adults. And I've listed some of the common cancers that you'll see in these age groups. So for instance, in children, the most common things you will see will be leukemias, brain and other central nervous system tumors, lymphomas. And for adolescents and young adults, you see quite a bit of breast cancer, thyroid, melanoma, and now a lot of colorectal cancer. Fortunately, the overall 5-year survival rates are approximately 85% for this age group, which is very fortunate. And as part of survivorship, patients have a lot of things that they want to do after cancer, which includes building a family. And many patients have this kind of predetermined expectation of becoming a parent. And survivors explicitly express the desire to have children. And the literature shows us that the preference is for them to have biological or genetically related children compared to using third-party reproductive adoption or options and adoption. So unfortunately, the very thing that saves their lives and permits survival also can damage infertility. And I like to categorize these things into 4 categories. So of course, you have your chemotherapy, and how much of an effect it has on fertility really depends on the patient's age, the type and dose of chemo. And for ovarian damage, it really can result in direct gonadal toxicity, vascular toxicity, and cause some cellular effects. Endocrine therapy, while not directly gonatotoxic, may result in age-related decline in fertility. So thinking of this, we think of our women with estrogen receptor positive breast cancer. A lot of times they are encouraged to be on hormone therapy for 5 to 10 years. So if the patient is already 35 years old, she may be 40 or 45 by the time she's done with that therapy. And then, of course, there's radiation. Again, this depends on the patient's age, the field, and the dose, but the ovaries and the testes are highly sensitive to radiation, with 2 gray resulting in 50% loss of primordial follicles in the ovary. And then finally, any surgery that is going to remove reproductive organs will obviously cause infertility. So why is addressing all of this important? Well, for survivors, it promotes autonomy and empowers them to make decisions that will hopefully reduce their long-term cancer-related infertility distress. For providers, it's our professional obligation to talk about these things and allows us to practice the principles of autonomy, beneficence, and non-maleficence. And then for institutions, it's important because it allows us to adhere to guidelines, which I'll talk about shortly, and really provides a standard by which, good cancer centers are measured. So ASCO, many of you may be familiar with these, first presented some guidelines on fertility preservation back in 2006, and it has undergone subsequent updates, and more recently, they're updating it now. But basically, it states that all patients at risk of cancer-related infertility should be informed of their risk, offered fertility preservation options if indicated, and referred to reproductive specialists as soon as possible in the course of treatment planning so that they have options available to them. So we know that we can do this and we have effective strategies for fertility preservation, but adherence to guidelines is actually quite poor. In the ASCO Quality Oncology Practice Initiative survey of 400 different oncology settings, they looked at records for nearly 7,000 patients of reproductive age. And what they found was that only 56% of women and 32% of men were actually counseled about their risk of infertility. And even those that were counseled, a large group of these patients, particularly women, were very dissatisfied with the information that was received. Another thing that is a problem is that utilization of fertility preservation services is low. And there are multiple factors that contribute to this. One is just poor access. Sometimes people don't know where to go. And in the United States, which is a large country with rural areas, this might not be easily done in those areas. We do have a lack of counseling and decision support to help patients make these decisions and learn about them. And then there's a general lack of awareness on the part of patients as well as providers. And as an oncologist, a lot of them say, hey, I know a little bit of this stuff, but feel very uncomfortable delving into the deep conversations about fertility and fertility preservation. And then the United States, and I'm not sure how it is in Brazil, but cost is a major factor with many insurances not covering this, and it can be quite expensive. So what is a multifaceted problem requires multifaceted solutions. So the MD Anderson Oncofertility Program was born of 4 different pillars, which includes the clinical arena, research, education, and advocacy and outreach. So the mission of our program is to preserve hope for future parenthood by providing rapid, streamlined access to high-quality fertility and family-building services. And the vision is to become the premier oncofertility program in the nation through excellent clinical care, impactful research, and effective education. And this is just an outline of the pillars of our program. Again, it's clinical care, research, education, and advocacy and outreach. And under each part, I'm going to go into a little more depth about what each of those pillars stands for and means. So first, I'll start with clinical care. So when I first got to MD Anderson, I thought, I'm going to be doing tons of fertility preservation. I'm going to be freezing eggs, freezing embryos, freezing sperm. And yes, that is a big part of our program. I would say it accounts for about 70% of the patients that we see. So with that, we do fertility preservation counseling. We do fertility testing, including ovarian reserve testing before patients start cancer treatment. And of course, we offer sperm banking, oocyte cryopreservation, embryo cryopreservation, and ovarian tissue cryopreservation. What I didn't realize is that there are a lot of other things that encompasses oncofertility that I would see. So we do a lot of post-survivorship fertility counseling and fertility testing. We offer expanded carrier screening. We see a lot of patients for pre-implantation genetic testing. Maybe they don't have cancer, but maybe they have a genetic mutation that will predispose them to cancer and they don't want to pass that down. And then the other thing I do see a lot of is third-party reproduction for patients who have become infertile and wish to utilize donor sperm, donor eggs, or use gestational carriers. So some of the strategies that we employed to improve access throughout the institution, the first thing I did was go around to all the various departments and introduce myself and talked about what I could offer the patients. And the tagline that I always use was that, hey, I know you don't want to talk about this too much. All I need for you to do as the oncologist is ask the question, and I will have that 2-hour-long conversation with them to make it easier on you. The other thing we did was generate patient education materials that were readily accessible. So if patients had questions or wanted to learn more, they could easily find that information. And over the years, we added additional personnel. So as you'll see in a paper shortly, we more than quadrupled the number of patients that we see each year. COVID brought along telemedicine, which actually has been a tremendous asset in helping us reach more people quicker. And then we also collaborated with the adolescent and young adult clinic at MD Anderson. So we see patients over in their clinic as well. And MD Anderson not only has its main branch, but it also has satellite branches throughout Houston. And we have a fertility specialist that goes to some of those, particularly the West Houston campus. So this is a little paper that we published many years ago after we first got started, and we saw like around 200 patients. Now we're easily seeing closer to 600, 700, 800 patients per year, depending on the year. So it has been a success. Next, like to talk a little bit about research. And there are a lot of different projects that we do work on. One is keeping a database of patients so that we could look at reproductive and oncologic outcomes in the patients that we counsel. They don't necessarily pursue fertility preservation, but even just the ones that we give counseling to. The other thing that was very important to me that I picked up on as I started taking care of these patients was that they did not have a lot of education and decision support. So we developed an interactive online decision aid that patients could work through to help them learn more about fertility and cancer, as well as fertility preservation options. There's values clarification exercises in this decision aid, and actually stories of different women, our patients who chose different methods and why they chose what they chose. And then the other area of research that we're now exploring is trying to be more methodical about looking at ovarian toxicity, especially when we're talking about some of the newer targeted therapies and immunotherapy. These are just some papers, and I'm not going to go into depth just because of the time limitations, but we did publish pathways and test it and found that we were able to decrease the amount of distress associated with making a decision and improve patient knowledge about fertility preservation. Okay, moving on to education. We have a lot of different educational initiatives under that pillar. One is to generate awareness in the general population. So for instance, during National Infertility Awareness Week, we will have tables, we will give out candy, usually little chocolate eggs, to let people know that cancer-related infertility is a problem and that there are ways to strategize and help patients have the families that they always wanted. We do a lot of peer teaching, both with the oncologists in our hospital as well as others who are interested. So it's not uncommon for us to have people shadowing in the clinic to learn how to counsel their patients better about fertility preservation. And we also do work a lot with trainees. So we have residents, students, fellows, nurse practitioner students that come with us and work and learn about what we do. So moving on to advocacy and outreach, as I said before, in the United States, for a lot of places, fertility preservation is not covered by insurance. So we felt that one very important thing to do was to get involved in legislation and policy. And I will say, as a physician, this was not something I expected to ever be involved in. I was never a political person, but I did get involved as an educational resource in the state of Texas. And this has been one of the most rewarding things that I've done. And we started some conversations with legislators about the young people in Texas who are essentially being, becoming infertile or sterilized by their cancer treatment. And just that conversation opened up years of dialogue that eventually resulted in us passing a bill that mandates coverage for some patients with cancer. So that was House Bill 1649, and I put some data on the slides just talking about how this was passed, and just want to note that this was a long process. It took us 6 years to pass it, but finally the governor signed the bill last June, and it was implemented at the beginning of this year. So that made Texas the 14th state in the United States to provide fertility preservation coverage. And this is a little outline of the United States and all of the states that either have something covered or legislation in place. Those are the states that are in green. And you see that there's a lot that are yellow that are contemplating legislation that will do that. So hopefully in the next decade or so, this whole graph will be green. So in conclusion, I really do believe that optimizing access to oncofertility services requires a multifaceted strategy, and essentially develop this program with that in mind. And really, it's the clinical care, the research, education, and outreach that all makes it better for our patients. And with that, just in the interest of time, I'm going to go ahead and close and turn it back over to you guys. Thank you.
I think you're muted, Dr. Bedoschi.
Can't hear you.
You're muted still.
Sorry. Dr. Terri, thank you for your wonderful lecture. We had a lot of compliments from people that are watching us live in YouTube and on the platform. It was a wonderful lecture, and then we're going to open a space for discussion. Now, I would like to introduce Dr. Jacqueline Yanomaier. She will present us fertility preservation in special populations. So she will present about patients with Turner syndrome, galactosemia, and also patients, adolescents that enter on idiopathic ovarian insufficiency. And Jackie, please, now the stage is yours.
Great, thank you. Good evening. Thank you, Dr. Bedoschi and Navarro and the Brazilian Society for Human Reproduction for inviting me to speak today on premature ovarian insufficiency and candidates for ovarian tissue cryopreservation. As he nicely introduced, I'm both trained in reproductive endocrinology and infertility and pediatric gynecology. I'm at the National Institutes of Child Health and Human Development in Bethesda, Maryland, and director of the Female Fertility Preservation Program at Children's National Hospital. Okay, so the learning objectives for my talk are to explain causes of non-cancer premature ovarian insufficiency, or at least some of them, discuss who are possible candidates for ovarian tissue cryopreservation, and then other considerations. So premature ovarian insufficiency is diagnosed in approximately 1% of women that are less than 40 and about 0.1% of women that are less than 30. other names include premature ovarian failure and premature menopause. And technically, the diagnosis by ESHRI are women less than 40 who have lost their ovarian function with amenorrhea for over 4 months, FSH levels or follicle stimulating hormone levels over 25 on 2 occasions, at least 1 month apart. And the mechanism is either follicle depletion or follicle dysfunction, and that varies depending on the diagnosis, if it's cancer, like what was just discussed, the type of treatment, the dose of treatment, the location of radiation, if they're going to receive a bone marrow transplant or not. But then there's this other cohort of girls and women who are either born with fewer eggs or their eggs are depleting at a faster rate. And so it's a different pathophysiology. And so who of these patients are good candidates for ovarian tissue cryopreservation, which we now know is standard of care as of the American Society, ASRM, Reproductive Medicine for 2019 for those receiving gonatotoxic treatments. So for overall girls and women with POI, they do have some ovarian follicles that are still there, but they remain dormant. And what can we do with these follicles? And so for most of you in the room, you know that the spectrum of ovarian function ranges, with one side being normal ovarian function with regular menses and labs and antral follicle counts. And then on the other end of the spectrum is subfertility, defined as diminished ovarian reserve, where you have regular menses, but decreased number of eggs, rising FSH levels between 10 to 20, dropping AMH levels of less than 1.1, and antral follicle count on ultrasound of less than 5 to 7. And so these are those markers of ovarian reserve that we can use to then hopefully these women then to pick them up before they reach premature ovarian insufficiency, which has that diagnosis I just discussed. But also for children, this may present as delayed puberty or primary amenorrhea. And so though they're less than 40, they may not go through any of that at all. The pregnancy rate, spontaneous pregnancy rate, has been described as 2 to 8%, but that also is variable depending on the diagnoses. For POI, 75 to 90% of the cases are idiopathic, where we don't know the cause. A big contender are these gonatotoxic treatments for cancer, for hemoglobinopathies requiring a bone marrow transplant, such as sickle cell disease, patients with lupus who are receiving cyclophosphamide or other alkylators, and surgery as well. And my focus today instead is going to be on the genetic 10%, which is either chromosomal or single gene disorders. So the most common cause of POI for chromosomal reasons is Turner syndrome. And then this is a short list of single gene disorders, and I'm going to be focusing on galactosemia and then touch upon these two others, which is autoimmune polyendocrine syndrome and blepharophimosis petosis epicanthus inversus syndrome, abbreviated as BPES. And so I think the big question for my whole talk is really who of these patients should be offered OTC that are not receiving these gonatotoxic agents. And so to answer that big overarching question, we have a protocol that's been up and running for about 3 years at the NIH. That's the gonadal tissue freezing for fertility preservation in girls at risk for ovarian dysfunction and premature ovarian insufficiency. And our inclusion groups, we have 3 now. It just expanded. The first group is prepubertal children with Turner syndrome or classic galactosemia, ages 4 to 12. Adolescents with recent POI, meaning that they've gone through spontaneous puberty and menarche, and then the periods just stopped. And their last menstrual period has to be within the past 2 years for them to be included in the study, and less than 20 years old. And then the third group that just got approved are children and adolescents with diminished ovarian reserve due to genetic or idiopathic causes. We modeled the protocol after the Oncofertility Consortium, where 80% is stored for the patient and 20% is used for research, which does include general pathology, histology analysis. And so our three objectives are to, one, look at the follicles in the tissue histologically and use machine learning and artificial intelligence to calculate follicular density, to do single nuclei RNA sequencing and spatial transcriptomics to better understand the mechanisms of some of these diseases compared to controls, which are either cancer patients or cadaveric organ donors. And then our third objective is to culture the tissue or the follicles and activate them or inhibit them. So the first diagnosis of Turner syndrome that I'm focusing on is defined as women who have total or partial absence of one X chromosome. It affects approximately 1 in 2,500 newborn females. And about 43 to 49% are monosomy in karyotype, meaning that the other 50% or so have a mosaic type of karyotype. And though we often learn that this phenotype of short stature, webbed neck, shielded chest, primary amenorrhea, and streak ovaries, along with coarctation of the heart, hearing alterations, etc., it is quite a spectrum that these patients present, where they may have few or they may have many of these findings. And the streak ovary is also not 100% in all these patients. Some have normal ovary or they have smaller ovaries. And so our study is really to try and figure out who and which type of patients freezing their tissue is appropriate for. So for girls with Turner syndrome, more background is that 10 to 50% go through spontaneous puberty, 5 to 20 will go through spontaneous menarche, and 2 to 10% will have spontaneous pregnancy, with more common pregnancies in those with mosaic karyotypes. The mechanism of disease is thought to be accelerated follicular atresia, which is seen on tunnel assays, which is a marker of apoptosis. It should be noted that there have been case series of Turner mosaics that have successful oocyte cryopreservation. And so Dr. Octay and Bedoschi did this case series that they stimulated 3 Turner mosaic girls ages 13, 13, and 11 with diminished ovarian reserve, and were successfully able to obtain 4 to 9 mature oocytes without any complications. In 2019, another group stimulated 7 girls ages 18 to 26. 6 of the 7 of them were Turner mosaics, and they were able to obtain 4 to 10 mature oocytes. However, what we don't know is the quality of these eggs, and are they at increased risk for aneuploidy because they are from women with Turner syndrome, or do they have increased aneuploidy because that is what's found in girls and adolescents in the general population? We also do not know the pregnancy outcomes of these patients, since they have not quite yet returned to use these eggs due to the young age that they froze them. There has been one case report also of ovarian hyperstimulation and egg freezing in a 7-year-old prepubertal girl that was a Turner mosaic, and they were able to freeze 6 eggs. So this really is pushing the envelope, because most of the times we counsel girls and women that they have to have at least 1 menstrual period in order to go through the egg freezing process, in order to have like an intact HPO axis that's functioning. This study looked at ovarian tissue cryopreservation in girls with Turner syndrome, and it did range from having girls with a number of follicles found in their tissue to those having fewer, and then those that had undetectable AMHs, they found no eggs or follicles in their tissue. Though there was this one patient that had a detectable AMH level, but no eggs were found. Of this group, the eggs that were analyzed in the histology, there was apoptosis and abnormal zona pellucida protein expression. Some were missing granulosa cells. They had diffuse or pale nuclear material, empty follicles, collapsed oocytes, shrunken granulosa cells, and contracted ooplasm. And so they suggested that the benefits of OTC may be limited to Turner mosaics with a sizable pool of normal follicles. And then this last study, which was interesting, is that they did ovarian tissue cryopreservation, and from the eggs that were extruded into the media during the processing, they were able to culture these during doing in vitro maturation. and were able to mature 8 of those eggs that were frozen for this patient. So our big questions at the start of our study were, who should be offered OTC, right? Should this be, I think it should be a case-by-case basis, and I'll show you our data in a second. Questions include, should we only be doing this if the AMH is detectable? Should it only be for Turner mosaics? And when should we be doing this? Should it be for the prepubertal girls before they lose all their eggs? Is younger better? Or on the flip side, should we be waiting for girls who go through spontaneous puberty and they have proven ovarian function and we know that there are follicles in that tissue? Should we wait and have the girls go through oocyte cryo first and then do ovarian tissue after if they have poor outcomes, or offer both? And then what about the girls that have Turner syndrome with Y, who are going to be having gonadectomies to reduce their risk of dysgerminoma and gonadoblastoma? Anyways, should we be freezing their tissue for fertility preservation? And then lastly, should we be using imaging as a screening tool to figure out who should be a candidate for OTC? And so this flow diagram by Octay and Lamarca that came out suggested using an AMH level of 2 as a cutoff for ovarian tissue cryopreservation and egg freezing. But my question is, how good is AMH of a marker in prepubertal girls? We know that AMH is released by growing preantral and small antral follicles. And so in prepubertal girls, where most of their follicles are in this primitive primordial dormant state and they're not releasing the AMH, how good is that marker? The younger they are, the range of AMH levels is very wide. And how do we interpret that? This study, which is a recent one, came out in 2023, is an expansion of their first study out of Denmark, looking at Turner syndrome, patients with Turner syndrome. They had 93 patients that underwent OTC, and they looked at the ovarian cortex fragments, and they did find follicles in 32% of the patients. They also did FISH to check the levels of mosaicism and compared it from the lymphocytes in the blood to the buccal cells in the cheek to the urine and the different types of ovarian cells. And they found differences between all of these different levels. Their first study showed that the girls that were Turner mosaics were the ones where the follicles were found, in contrast to those that were Turner monosomy. And so this data here, I just submitted to ASRM for next year's meeting, is our first 15 patients that have gone through our protocol. And the range of patients, the average age is 8.6 years old, range from 4 to 17. These are the various karyotypes. The different colors are showing that the ones in dark gray are the patients that we removed both ovaries for Turner syndrome with a Y component. The ones that are in gray, both dark gray and light gray, are showing that they had undetectable AMHs, which for us correlated with no follicles seen in their ovarian tissue. The ones that are in blue are showing a detectable AMH that correlated with follicles seen in the tissue. And then we do have one that had an undetectable AMH, but we did see primordial follicles. Of note, 2 of the ones that had a detectable AMH were mosaics, and the other 2 were monosomies. Over here is the histological images of patients with streak ovaries and no follicles, versus this one is patient number 8, who's a Turner mosaic with primordial follicles seen here. So moving on to single gene disorders of POI, the main focus of our studies are on galactosemia, which is a mutation in the GALT gene. And so this is where there's a metabolic cause. It's a metabolic disorder where the body is lacking the enzyme to break down galactose, a sugar that's found in milk, which can accumulate and damage the brain, the eyes, the liver, and the kidneys, leading to cognitive impairment, hepatic and renal failure, as well as POI. It is a rare inborn error of galactose metabolism that's autosomal recessive, and the prevalence is about 1 in 30 to 1 in 60,000. In the US, it's detected upon newborn screening on every child. And with early diagnosis and rigorous dietary restriction of galactose, most of the infants survive and thrive very well. The long-term sequela of the neurodevelopmental impairment, as well as POI affecting 80% of women, can lead to primary and secondary amenorrhea and infertility. The mechanism of follicle depletion is not well understood, although here are some of the hypotheses, which include direct toxicity of galactose and metabolites in the ovarian tissue. These few studies did look at the populations with classic galactosemia and found that 45 to 68% had spontaneous menarche. And this one study showed that 77% were diagnosed with POI on average age by 13. But what's interesting is that of these women, there was a cohort that actively tried to conceive. And of those, 43% were able to spontaneously conceive, which is different than the low 3 to 5% that's quoted for spontaneous pregnancy of POI of all of the different conditions. The pregnancies, there were 20 of them and 9 women, and the miscarriage rate was about 25%, similar to the general population. There is one case report in the literature of ART being used in a patient with galactosemia with one successful pregnancy using donor egg. It's a long time ago, that publication. And then this is a summary of the world's literature of case reports and case series of ovarian tissue with patients with classic galactosemia. And of note, when they're younger, in their prepubertal age, there are follicles seen. In contrast to when they become teenager, there are no follicles seen in their tissue. This is a nice video that's available by Margita et al. That is a surgical laparoscopic technique using cold scissors and an endoloop, which is the technique that we try to use as much as possible in our patients to minimize thermal damage during OTC. Of note, this patient had classic galactosemia. Her AMH level was undetectable, and there were follicles detected in the ovarian tissue. Lamarca, again, has this flow diagram showing recommendations for, or I guess suggestions for ovarian tissue and egg and embryo freezing of these patients, though there are no general recommendations due to the lack of sufficient data. Because this is a genetic mutation, PGTM can be done to select for embryos without the GALT mutation. And so for our protocol thus far, the bottom half are patients that are representing our controls. These are patients with cancer or other diagnoses that require gonadotoxic treatment and have underwent OTC. And so for our controls, our average mean follicle density is about 34. So in contrast, those with classic galactosemia had less than half of that follicle density, though we did see follicles in their tissue. So what's interesting is that we saw the follicles in the tissue, but their AMH levels were undetectable to very, very low, which is different than our Turner syndrome population, where you had a correlation of undetectable AMH and no follicles. Or here in this population, I don't think that AMH is turning out to be a good screening tool for classic galactosemia, and patients should not be excluded if it is undetectable. Oops, sorry. So then back to that big question is, who should we offer this for classic galactosemia? Should it only be if the AMH is detectable? I don't think so. Age for prepubertal girls only before they lose all their eggs, again, is younger better? Or should we have those try to go through egg freezing first and then OTC afterwards if they have poor outcomes? And should we be using imaging as a screening tool? Oops. So our third population that we've been studying are adolescents who undergo POI as teenagers. And so we have 3 girls that have autoimmune POI, and unfortunately in their tissue we have not seen any follicles. So perhaps this condition might not be the condition we should be doing OTC for, though it's still open. The protocol is still open for this condition. And then I have one patient with BPES, which is a FOXL2 mutation, who was having decreasing AMH and irregular periods. She was 18 years old, and so I tried to freeze eggs for her. Her first cycle was canceled due to no response to gonadotropins, and the second cycle, she had premature ovulation, and so no eggs were retrieved during the retrieval. So after those 2 cycles didn't work, we then went on to ovarian tissue cryopreservation, and we successfully froze tissue, which showed a mean follicle density of 11.4 follicles per millimeter squared, which is less than the cancer control patients, but still a good number. And hopefully she will be able to use that in the future if needed. So lastly, I'm just going to briefly go over in vitro activation. So for patients with cancer, it has been successful to transplant the tissue back, and there have been over 200 pregnancies that have come from that. But in these rare genetic disorders, there have been no transplants back yet. So we don't know if it's going to be successful. And so in contrast to IVF, which is targeting the gonadotropin-dependent part of folliculogenesis, in vitro activation is looking at the gonadotropin-independent portion. And so these different groups, what they've done is they've taken out the ovarian tissue in women with POI. They've fragmented it and cultured it in AKT stimulators to stimulate the remaining dormant follicles that are in the tissue. And then they surgically place that tissue back. The patients then go through IVF to retrieve eggs, make embryos, and do an embryo transfer. And so a summary of that literature, moving forward, is here. So a combination of some of these studies did this with frozen tissue, some with fresh tissue. One study did this without the culturing and just with the fragmentation. There have been 13 to 14 live births using this technique. And so this is hopeful and promising that maybe this can be done in the patients such as Turner syndrome or galactosemia in the future. Alternatively, if we can figure out in science how to culture a primordial dormant follicle all the way through in vitro in the dish to a mature state, then we won't have to transplant the tissue back at all. But I think we're a number of years from that state. So as you move forward and you see these rare conditions, think about who you think OTC may or may not be suitable for, and who it should be offered. These questions of how and when and what the criteria should be are what our study is trying to figure out. And then I personally think that these rare conditions should be done under a research protocol so that we are learning who are the best candidates for this procedure. And so with that, I'd like to thank all of those at Children's National and our lab at the NIH and our students and fellows that work with us in making all of this possible. And if you have any patients that that have POI that you think may be interested in our study, you can send them actually from Brazil or anywhere across the world. If they can get to a U.S. site, the travel transportation from the U.S. city to the NIH, the surgery, the testing, and everything involved is covered if they're under 18 for the patient and one parent. And so just keep that in mind if you have any patients that would qualify.
Jackie, congratulations for your wonderful lecture. It was amazing. For sure, Jackie, you are in the forefront of knowledge. It's amazing to hear your talk and your experience and to be able to share this in Brazil, these specific situations of fertility preservation. I would just speak in Portuguese a little bit. Pessoal, Agora, quem tiver alguma dúvida e quiser aproveitar para mandar perguntas para a gente poder estar discutindo com os convidados, a gente tem a possibilidade aqui, a gente tem ainda mais alguns minutos para poder estar aproveitando o tempo deles. I just open now for the session for discussions, and I have some questions for you. So, Dr. Terri, I would like to ask you two specific things, and then Jackie, I will make some questions for you, and I want to see your answer because I'm really, I think, specifically in Turner syndrome patients, I have some thoughts, and I want to share with you, and I want to see what you think about that. So, Dr. Terri, the first thing, I would like to know how it works at the hospital when the patient comes with a cancer diagnosis, like a breast cancer diagnosis. She first is seen by an oncologist, right? And if she is in a reproductive age, how the referral happens, how the patient reaches the fertility preservation unit. There is like a pop-up in the screen of the doctor saying, look, you need to refer this patient for fertility preservation. How it works in the hospital?
Yeah, that's a great question. And honestly, that answer has evolved over time, and there are multiple avenues to get to us. So we always do require a referral from the oncology team. However, more recently, they've instituted the idea of patient navigators. So the navigators start talking to the patients before they ever hit the door. So a lot of times, we'll even sometimes see patients before the oncologist. We also have patients that self-refer. So one of the things I did early on was create little pamphlets and put them in the learning centers and patient areas so patients knew to ask, because certain departments were very good at routinely. They have their algorithms, and Oncofertility consultation is part of that. But say there's a patient with multiple myeloma, which typically affects older people, they're not so in the know about the Oncofertility service. So patients would sometimes then go to their provider and request the referral. We've tried for years to get, an EMR alert, but there is a lot of alert fatigue in our institution. So we trialed it, and it actually didn't work quite as well for us. But because we've been highly visible throughout the institution in terms of giving talks, certainly the departments that take care of a lot of young reproductive age people, it's part of their algorithm.
So even that you have a service inside the oncological hospital, you still have some barriers that patients face to reach the fertility preservation unit, right?
Absolutely, yes, still.
No, but it's amazing. It's amazing. And I have a second question for you, Dr. Terri. You shared with us that you were expecting when you first built the service and you start working at MD Anderson, that you were thinking about doing the appointments and indicating the sperm freezing, oocyte freezing, but then you saw that the range of your work is much more wider, right?
Yes.
So you need to discuss like third-party reproduction and also the PGTM for carriers. So I would like to ask you, Dr. Terri, if you have like a routine through your appointment where at the first moment that you receive the patient, do you discuss this third-party reproduction, or do you have like how can I say, a routine that you need to do like a checklist? And I need to, even if the patient doesn't want to do the fertility preservation treatment, I need to talk to you about third-party reproduction now or adoptions. How it work for you?
So I'm glad you asked that question, because that is part of my routine conversation with every patient I see. Because remember, going back to the situation in the United States, a lot of people just simply can't afford this therapy. So I don't want this consultation to end up, being a sour taste in their mouth. Like, oh, she told me all these things I could do if I had the money. And, sometimes people don't have time. They're too sick to freeze eggs or freeze ovarian tissue. They're just acutely ill. So I always do try to plant that seed of like, okay, worst case scenario, you lose your fertility. There are still ways for you to become a parent. You know, if you want to do this, you might have to think about doing it a little differently, but keep it in the back of your mind that there are still options, and come see us when it's that time.
Amazing, amazing, wonderful. It's good to know that you discuss this in patients, even in the first appointment. That's amazing. And I'm sure that who benefit most are the patients. That's great. We have already some questions, but I will just make a question for Jackie. Jackie, there are some reports about PGTA results in patients with mosaic Turner syndrome. And these PGTAs, Jackie, cycles, they don't show that the patients have more risks of aneuploidy or even more risks of sexual chromosome aneuploidies. It's not it's conflictant, but there are some groups that believe that the patients that are able to get some oocytes, probably these oocytes can be healthy. Probably the oocytes that have absence of an X chromosome will enter in apoptosis. What are your thoughts about that, Jackie? What do you believe on that?
Yeah. So that there one study that's out of the Netherlands, they did do fish and compared the eggs versus the granulosa cells versus the stroma cells. And because the egg is stuck in prophase 1, you can't like count the chromosomes. That they did it by intensity, but they felt that what they calculate is that the eggs had a normal amount of X chromosomal material. And so it's probably more so that the granulosa cells had more aneuploidy than the egg itself. So, you know, I would lean in that direction, that the eggs that make it probably, you know, have the proper amount of X chromosomal material. So I think that we'll see with time, and we'll see what happens with those eggs that have been frozen, like in your study with Dr. Octay, when those patients return to use them and they fertilize what's in there. But I think what's also hard to know is that the aneuploidy rate in the general population makes this U. So the highest aneuploidy rate are in the teens. It's, you know, the lowest in the mid 20s, 30s, and then goes up in the late 30s. And so if we're freezing these eggs on these teenagers, also, are they having a higher aneuploidy rate just because they're younger? I don't know. But I will say that fish is not as straightforward as like lots of these publications, or like from the lymphocytes. It's like, oh, fish, easy fish, X and Y and 21. We've been trying to do it in the slides, and it's very challenging. And then to differentiate the different types of cells with the fish, it's hard. So I commend the Netherlands for being able to do that in the tissue.
Yes. And Jackie, do you believe that you need to screen patients like at mucosal, blood, different sites, or only the blood is good?
I don't think we know, but we're collecting buccal, urine, blood, and tissue. And so I think we're doing similar to the Netherlands, and in time we'll know if the blood is good enough, but maybe it is, and maybe it's not. Maybe a different cell type is a better screening. I don't know if urine would be better, but I think we'll learn. I think the other thing that's sort of emerging that's interesting is there is thought that women in the general population lose one of their X chromosomes. And so there have been an uptick of patients who are pregnant doing cell-free DNA and finding Turner syndrome in themselves when they're already pregnant. And do they really have Turner syndrome and they have like no symptoms, or did they just lose one of their X chromosomes with age? And so I think that will be another emerging area.
Wonderful, Jackie, wonderful. I couldn't agree more. Now I will share some questions from the audience. Dr. Alexandre Lobel, a good friend of mine, and who also worked in New York with fertility preservation. He made a question for Dr. Terri. Dr. Terri, when you began the implementation of the Oncofertility program, did you encounter resistance from oncologists in referring patients? How did you overcome this? And the second one, I believe that probably you answered, but are there still challenges in patient referrals?
So in terms of patient referrals, the challenges are more just people being aware, but I find the oncologists to be incredibly receptive. And, when I went to talk to the different departments, it was like, let me have that difficult conversation. And I think I established trust with them. So, it's like, I'm always going to send the note back to you. If a patient says they want to do something, I'm going to confirm with you. Do you think it's okay? Is there enough time? And sometimes the oncologist will give me the heads up and email me or text me and say, hey, this patient really doesn't have time to do this. So it's more of a team effort. So I think that all patients warrant the discussion. I mean, I've had people that were terminal who knew that they couldn't do this. And I remember one patient was like, thank you for addressing the part of me that always wanted to be a mom. I know I can't do it, but thank you for having that conversation with me. So we approach it more than that way than we're trying to make everyone do fertility preservation. So I think we've established a lot of trust and team building over the years.
Wonderful. Dr. Terri, just for, I'm curious now, from the patients that you see at your program, how many of them go forward and actually do fertility preservation treatment?
So if you're talking specifically about women in ART, it's about 20% out of all the patients that we see.
And for men, because sperm freezing is easier, right? For men,
yeah,
it's the same proportion.
It seems like such a low-hanging fruit. It may be slightly better, but it's actually not very good either. Marginally better, actually.
Okay, wonderful. And Beatriz, she first she make compliments for both of you of the presentation. Actually, a lot of doctors here in Brazil saying congratulations for the wonderful lectures. And she made a question for Dr. Terri, but I will extend for both because Jackie also is used to see more children and adolescents. She asked if you could, how do you make the approach when you counsel patients in the children and adolescent about fertility preservation? Do you have anything in mind that you would like to share with us?
Dr. Mark, do you want to go first since you're the pediatric?
Sure. You mean like in the counseling or?
In the counseling, when you approach adolescents, children to do some fertility preservation counseling, do you have any kind of tips to give us or any kind of care that you think it's good to have with when you approach this specific population?
Yeah. So for the patients that come through Children's National, the ones that have cancer or a hematological disorder, I usually do it by telemedicine, and I have like a whole PowerPoint that I go through, and that is my approach. And it came out of COVID, but it's like a very nice 45-minute presentation, and I send them that presentation at the end so that they can review it and ask questions. And then meet with them a second time if they want to or need to, especially the bone marrow transplant patients who have more time to decide typically. In general, if they are from 0 to 12, 13, it depends on the patient themselves. I don't require the patient to be there during the conversation, and it's usually just the parents. If they're in that tween stage, I let the parent decide how much they want me to tell them. Do they want me to tell them separately, more simply afterwards, or I leave it to the parent to discuss on their own terms? And then usually if they're around 13, 14, then I tell the parents that I would really like them to be part of the conversation, to listen, because they have to, if they're 7 to 11, they have to give some sort of assent that they understand that they're going to undergo that surgery. And it doesn't have to be extensive. The parents can tell them, they're going to have surgery on their bellies so that they can be a mommy in the future. And that's all that they really need to explain to me. But to do the OTC, they have to be able to explain that to me before I take them to the operating room. For, again, the patients that are like 13, 14, those I will do the in-depth both egg freezing and ovarian tissue counseling. And so they need to understand and then make the decision if they'd like to move forward with egg freezing. And then I refer out to our local IVF centers, and they'll get that counseling again at those centers. And then the ovarian tissue, talk them through it and show them the pictures. I feel like those are my tips and tricks. Oh, and I talk about puberty a lot too in those discussions, because half the time, like, they don't realize that a lot of them are not going to go through puberty, and I will be on the back end to do their pubertal induction and hormone replacement, and that'll be part of their care later on. So that's also part of my counseling when I talk to them. And regardless of what they choose, I think all the families are really just grateful that they receive that information and knowledge.
Wonderful, Jackie. Do you think that, I don't know, probably it's a shared decision among the parents and also the children, but what do you think when you counsel, Jackie? Do you feel some resistance from the adolescents? It's because sometimes, Jackie, I have just a few experience talking, seeing patients in adolescence phase. And for me, Jack, as a doctor, dealing with adults, then it's different to see adolescent patients. I don't know, I feel that maybe at the appointment, Jack, there is not a lot of interaction. So, and usually the parents are together. And sometimes I get afraid that maybe the adolescents are a little bit bored because their parents are there in the same place during the appointment. Do you feel this resistance, Jackie? Do you discuss separately or together? The parents and the children together?
I discuss it together. If they're older, I'll do a confidential exam like I do for, general pediatric and adolescent gynecology, and ask them on their own and make sure that they don't have, and see if they have any questions on their own. I haven't really met resistance, but I do think that if there is question, we do have ethics that can come and get involved if there's any feeling of like coercion from the parents to the child. But usually after they meet, like, even if they disagree, they'll go off on their own, they'll talk about it, and then they'll come back to me with whatever the shared decision making is between the child and the parent. Terri, what about you?
Yeah, and I mean, I think it speaks to the point that the maturity level between these ages is just so variable. I've had a 9-year-old with actually Turner's who could, she was asking question, my eggs are in there, and yes, I want to become a mother. Like, she could verbalize that. And I've had 14-year-olds and I'm like, I'm not going to touch you. So, and as far as, the older girls, I do take them into the exam room separately. I'll just say, hey, Mom, I want to do a quick exam. This is part that, I would like to just see her by myself. And I've never had any resistance to that. And I actually just point blank say, hey, is this something that you want to do?
Wonderful, wonderful. And we have 2 more questions from Fernando. I think that when you were answering one of the questions, Dr. Terri, he said that the line of the approach that you use, it's very important. And I believe that this is related to the discussion with the oncologists, okay? And so to be multidisciplinary. And Fernando asked, Dr. Terri, could you share the approach lines that you apply on your routine? So do you usually call to the oncologist when you do the treatment? Taking the opportunity from Fernando questions, sometimes now patients come to do egg freezing, and then sometimes the oncological team wants to use the generation alloc. and we can have a flare-up effect, and then we can have a hyperstimulation syndrome. So how do you do the approach? Do you talk to them? Do you discuss, look, I did egg freezing, it's amazing, please don't use the generate analog, or yes, we use but delay, let's use antagonists. How do you do this?
So typically, after we do the consult, I always follow up and say, hey, we saw your patient, my notes attached, she wants to do this. Do we have the time? And I confirm that. And then when I trigger the patient, I let the oncologist know that we're getting ready to go. She's almost done. And I always warn them that if they got HCG, the pregnancy test is going to be positive. That was something I learned really quickly.
Wonderful tip, wonderful.
She's not pregnant. And then
and I believe that they always do before chemotherapy, right? They will do and it will be positive. Yeah,
everyone's like freaking out. But I do, and I actually educate the patient too. It's like, I know that Lupron or Goserelin is going to be part of your care plan. Please, talk to your oncologist, let them know. I will let them know when to give it, or some, that's also verbalized to them, but the oncologists usually don't listen. So I really rely a lot on the patient.
Wonderful.
Remember that.
It's the same in Brazil. Please, I will tell him, but please, you need to remember him, okay?
Remind them. Yeah.
Okay, wonderful. So Terri, to make when you see the patients, you maybe reply the oncologist, look, I saw we're going to proceed with egg freezing. Then by the trigger time, you also say, look, the patient is almost ready. And if there is any concern about hyperstimulation syndrome or any kind of advice, then you do a third contact with him, right?
Yeah, and it's very easy because I'm in-house, so I can email, a lot of them I can text. It's just really easy to just say, hey, this is where we are.
Amazing. And Dr. Mauricio, he's a good friend of mine as well, and he works a lot with fertility preservation here in Brazil. He made that question for both of you. Sometimes we see adolescent cancer patients, post-pubertal, 14 years old, to oocyte cryopreservation, but they are Virgo, they are virgin. What's your approach in this case? How do you do egg retrieval, or how do you counsel these patients?
So we're fortunate. So I have a joint appointment with Baylor College of Medicine, Texas Children's Hospital. So I'm in a children's hospital. We have a women's center attached to it. So, and, I talk about this with the patients. We do abdominal monitoring. And for nearly all of my cases, we've done transvaginal retrievals. I think I've had to do like one abdominal retrieval, but it was unrelated to the fact that she was virginal. So we just have an honest conversation up front, how you might feel after, but, everything's under anesthesia. So that makes it a lot easier. And so far, we haven't really run into any problems with that.
Dr. Terri, do you make the patient sign a specific term that maybe the immunol will be ruptured, something like this, or no? Just counseling.
I don't sign anything specific, like a consent form for that. But in my documentation, I talk about the fact that we're going to be doing a vaginal retrieval under anesthesia.
And Jackie, the same for you, Jackie?
The same. And then if there is any, tear or damage, that it's repaired at the time after the retrieval is complete, but that the ultrasound is really small and we put gel on it. And so usually it's like atraumatic.
Wonderful. Jackie, do you know that our friends from Turkey, they do abdominal retrieval, right? A lot.
For the kids?
In kids, in also adults. I think that maybe it can be something cultural related, but sure. They use the transvaginal probe, but to do a transabdominal retrieval. A lot, yeah. Jackie, a lot. Now in Instagram, I can tell you. And
successfully?
Yeah, no, a lot. They do, like it's a routine for them to do abdominal retrieval using transvaginal probe, but yeah. It's abdominal, yeah.
Cervical cancer where you don't want to go through the vagina, or someone has a very high ovary or something, but wow.
Yeah, no, it's amazing. I think that their experience on that must be shared because it's amazing. And the last question from the audience, Dr. Alessandra, a good friend of mine, she asked, another disease that impacts ovarian reserve is endometriosis. what do you think about ovarian tissue cryopreservation for adolescents with endometriosis? Maybe, Jackie, this question can be for you.
Oof.
Difficult.
I think that's unknown territory. I don't have an answer for that yet. I think it also depends if they've had, endometriomas and resections of the endometriomas that or not, or if their AMH levels are plummeting and going below 1 after that. But I wouldn't necessarily do it at this point in time.
There is just a few literature on that, right, Jackie? Not so many cases of ovarian tissue cryopreservation in endometriosis, if I'm not wrong.
Mm-hmm.
So now I think that we answered all the audience. Also, our time is just running out. Dr. Terri, Dr. Jackie, it was amazing to have you both with us today in this webinar. I made a promise for them, and now I want the Brazilian audience also to help me. Next time, the invitation will be to be in person here and during Carnival season. So I hope that I can make this happen in the future. But thank you so much, Terri, Jackie. It was amazing to hear your experience for us. It was very it was very important for us. Thank you so much.
Thank you for the invite.
Yeah, thanks for having us.
And so nice to meet you, Dr. Jackie.
Well, likewise, Dr. Terri. See you in person sometime soon.
Absolutely.
Okay, guys. See you. Bye-bye.
Have a good night. Bye-bye.
Bye-bye.